All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Reller Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Reller Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content which is provided as is and without warranties. We are looking for a sports medicine physician to join our team. This is a full-time clinic-based physician working in a sports medicine clinic. Please feel free to pass our information along if you know of a qualified candidate. For all athletic trainers who are intending to get live CEUs from the VOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@rellevasportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Dr. Reller is the owner of Clearwater Family Medicine and Allergy in Clearwater, Florida. Before going into medicine, she was an electrical engineer. After completing medical school and family medicine residency at the University of Maryland, she moved back to Florida and joined her father in practice to learn the clinical practices of allergy and asthma. She started her own family medicine practice in addition to seeing allergy patients. She has always had a passion for wellness, nutrition, and fitness, and has since found the perfect combination of these things in the field of obesity medicine. As an obesity medicine specialist, she helps patients live their healthiest and best lives so that they can prevent chronic disease, move better, and breathe better. She does this by encouraging patients to make sustainable lifestyle changes so that they can live a healthy, confident, and energetic life. And she's speaking today about obesity medicine for athletic trainers. So I'll have you take it away.
All right. Hi, everybody. Nice to meet you virtually. Thank you, Dr. Henney, for having me today. I'm excited to share about obesity medicine to you guys. Just a caveat, I had some presentation notes that I apparently can't see, but that's okay. We'll go with what we can do. And I forgot you had my introduction, so thank you so much for the introduction. Yeah, so I'm in Clearwater in Palm Harbor, Florida, and I do obesity medicine. And just to let you know, I did almost go into sports medicine, but I was convinced otherwise to do the allergy and asthma side. So, but here I've kind of reverted back and found obesity medicine. So just want to give you guys an overview. So here are my disclosures, a couple investments, but really nothing relevant to today. Okay, and so I wanted to tie obesity medicine back to athletic training, and it's kind of obvious, but not obvious at the same time. So there are definitely sports where obesity can be affecting individuals, especially wrestling, football, maybe track and field, like shot put and things like that, or things that come to mind for me. But you know, it's really important, I think, throughout their athletic career, but also or perhaps in retirement and when they sustain an injury. So I was looking for some cool articles on, you know, things that are affecting these athletes, and, you know, here's some headlines that we found here. So the NFL has even created like a wellness challenge and a screening thing for screening for chronic diseases for people who have retired from the NFL because they have this higher influx of obesity for them. And I had the stats, but I think it's like a third can end up getting obesity after they've retired. And then there's some other cases here. There was a marathon runner who was really focusing on carbohydrates and energy drinks and to sustain him in his runs. And when he kind of retired, he had developed type 2 diabetes. So the associations of the chronic diseases from obesity are definitely prevalent in the retired and injured athletic population. But even still, I think the biggest thing I want to take for you guys to take from this is how you can prevent it in the first place and to change some habits that maybe these athletes are undergoing at this time that maybe aren't the best healthy habits that are going to sustain them forward in their lives. So creating healthy habits now, even if, they're still athletes and stuff like that. And I was reaching out to an athletic trainer I know, and she had mentioned that when she said maybe a third of people who have sustained an ACL injury end up gaining weight in their recovery period. So, it's also relevant now, like they can't, if their physical activity is decreasing, definitely have to change all the other lifestyle things as well to help balance that. So the objectives today are really to understand and recognize obesity as a chronic disease and medical condition. It's not just, willpower. It's not calories in, calories out. It is a chronic disease, and I'll explain why. And then we're going to talk about evaluation and treatment of obesity and medication treatment and side effects as well. So I really want you to tie this back into your athletic training career and how, it can affect you and your patients. And this is I kind of already said this, but really creating sustainable habits for your athletes for the future so they can prevent all these chronic diseases. So 1 in 3 people in the US have overweight. That's about 33%, and 2 in 5 have obesity in the US. That's 42%, and 1 in 11 people in the US have severe obesity. I had some adolescent data too, which I don't have off the top of my head, but it's in the last 20 years, the adolescent population is also getting overweight and obesity as well. So this is the definition of obesity by the Obesity Medicine Association. It is defined as a chronic, progressive, relapsing, multifactorial neurobehavioral disease wherein increased body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. I know that's a mouthful, and we're going to break it down, okay? Oops. Okay, so basically a disease is an altered state of an organism's body or part of its body, which interferes with the standard operations, and it has these signs and symptoms. So I'm going to show you why obesity is a disease. So a chronic disease is continuing again and again for a long time. It's always present. So that's the chronic nature of it. Progressive means that it increases in extent or severity. And relapsing is kind of like you can have a recurrence of symptoms after it has been improved, or you kind of backsliding, worsening, and kind of keeps coming and going. So obesity is affected by environment, including an in utero environment and other environmental things like chemicals and environment of what you bring to the home. And it's affected by genetics. And we think it's also affected by microbiome. I mean, I think there's pretty good data out there, but it's still under investigation. And then also, affected by what you're intaking and your expenditure as well. And this slide, is kind of also focusing that there's a link of type 2 diabetes with obesity as well. So basically, it's not all genetics, but it is partially, and it's a lot environment, and also includes, epigenetics as well. So it's a neurobehavioral disease. What does that mean? So basically of the connection between the nervous system and behavior. So there's certain chemicals in the brain and hormones in the body that are dysregulated. Example would be, the reward center of the brain that's driven by dopamine. That's kind of dysregulated in that. Like you want something more and more, and you have higher levels of dopamine that are needed and released in order to feel pleasure from it. So like it's like an addiction pattern. Like it would work the same way with sugar as it would work with alcohol or other substances. This just drives us to have certain behaviors due to the hormones themselves. And we're going to go over these, but leptin and ghrelin causing these sensations that you feel. So leptin induces satiety and ghrelin induces hunger. And we're going to talk about that. So these are the regions of the brain, and they all work in, concert to control eating behavior and everything like that. So there's the cognitive executive function of the brain that we're going to talk about at the very end, and then also the hedonic and homeostatic. And they all integrate together to balance everything. This slide really shows the fact that, on the right side, there's early life events, there's the imprinting and the epigenetic role of the environment playing on obesity, and the brain and the gut health, like the gut-brain axis, basically, and other things of how everything is just really related, including the, the habits and the reward and all the different centers of the brain. So everything is really related, and obesity and the environment and lifestyle are all affecting and causing obesity. So I mentioned ghrelin, which we will talk about more, but ghrelin is released from the stomach fundus. It's acting in the hypothalamus. It's the only hormone that causes hunger. And it's very much affected, and we're going to talk about more of why it's altered in obesity, and it obviously is peaking before meals to increase food intake. The other important hormone here is leptin. Leptin is the satiety, one of the satiety hormones, and actually it's the fat tissue or white adipose tissue actually gives off leptin. And it's interesting because leptin levels are actually increased in obesity, so you think there'd be more satiety, but we also think there's something called leptin resistance in obesity, meaning that the people are not really responding to leptin to have satiety sometimes. So you see, like, some people say they're always hungry, some people say they're always full. So everybody really is going to be different in how they manifest the hormonal responses, but in general, leptin is the satiety hormone, and it is proportional to the amount of fat tissue. And then the very popular hormone now, we're going to briefly discuss it this second, but it's GLP-1. So that's given off by some of the cells in the small intestine. It acts at the pancreas to release insulin, and at the hypothalamus. So releasing insulin and at the hypothalamus both increase satiety, and in the gut, it's delaying the gastric emptying. So this is why the GLP-1 receptor agonists are very potent in reducing satiety for obesity medicine. As obesity medications, and we'll discuss those in a little bit too. So I'm not mentioning all these other hormones in here, but these are all affected and all play a big role in why we say obesity is a chronic disease. So then I also, in that definition, we mentioned adipose tissue dysfunction. So the accumulation of adipose tissue makes this problem, worse, obviously, but what it acts as is like an inflammatory organ, if you will. I mean, the fat tissue is essentially its own organ as well. It's giving off inflammatory markers like IL-6 and TNF-alpha, adiponectin, and obviously I mentioned the leptin. So it has all these other players in there. And just imagine what all the inflammation is, causing in the body. It can act on all these cytokines can act elsewhere in the body and affect inflammation. And then I mentioned abnormal fat mass physical forces. So there's some of the obvious, right? Joint pain, arthritis from just having too much weight on the weight-bearing joints. There can be rashes under skin folds, typically the breast or the abdominal pannus. And then skin tags, which we often see in insulin resistance and diabetes as well. And that has to do with an increase of the melanocytes. And, everything is also related to those inflammatory markers I was describing too. So obesity is a chronic neurobehavioral disease with severe health consequences. So it's lifelong, it relapses, it's multifactorial, and it's a neurobehavioral disease affecting millions of people worldwide, and it can have serious health consequences. So it's obesity is a disease. It needs to be managed like any other disease, with or without medication. Not everybody has to be taking medication. And weight is really just a symptom. So we talk about in obesity medicine, like treating the whole patient, and what the patients really want, are increased energy, improved health. They want to have reduced pain. They want to explore and travel and act like other people who don't suffer from the disease. They want to be able to get on the floor and spend time with grandkids. They want to fly on the airplane without having to buy 2 tickets. Like, these are the things that the patients really want. And then what doctors want. So doctors want to take a patient-centered approach, but we also want to see those improved lab markers. We want to have improved blood pressure control, a less risk of disease, of all that we're going to talk about in a second, and less medications overall. So the dangers of untreated obesity, I had some good stats here, but I'll just have to go on the fly here. But so we want to treat obesity to reduce these risks of these other chronic serious medical conditions. So heart disease and cardiovascular disease, the #1 killer worldwide, and obesity is definitely a risk factor for that. And diabetes is also very much linked to obesity. Sometimes chicken or the egg, we don't know which one comes first, but diabetes is a huge risk factor for cardiovascular disease in and of itself. And then cancer. Obesity increases the risk of many different types of cancer as well. So it affects every system of the body. So cardiovascular system, heart attack, stroke, peripheral vascular disease, hypertension, congestive heart failure, prone to more clots, varicose veins. In the endocrine system, we're talking about diabetes, PCOS, gout, infertility. The GI system, non-alcoholic fatty liver disease, or NASH, and now they've changed that name a couple times now, but that's very relevant. Gallstones, GERD, hernias. In the kidney system, that can cause renal cancer, renal stones. And then the biggest cancers associated with obesity are breast cancer, endometrial cancer, esophageal cancer, colon cancer, and pancreatic cancer. Once again, hematology can, prone to the risk of clots, multiple myeloma. Pulmonary is very important. Obstructive sleep apnea is very much related to obesity, or an obesity hypoventilation syndrome, as well as asthma. Neurologic system. So the Alzheimer's disease has been very much related to obesity. It's also been called type 3 diabetes. And so all of these things are stroke, vascular dementia, intracranial hypertension can be all related to obesity. Obviously, the musculoskeletal system with arthritis, myalgias, impaired balance and gait. The skin system, so we mentioned some of these already, like skin tags, acanthosis, nigricans, also like the prone to ability to form venous stasis ulcers. And then the psychosocial consequences are just huge, right? Anxiety, depression, body image dysmorphia, libido and sexual problems, and eating disorders, just really low self-esteem and hopelessness. So the root cause, one of the handouts I gave you discussed that. I'm gonna go down on the next slide. But so we kind of already talked about this a little bit, but the genetic predisposition, the hormones at play, and metabolism all can contribute, but also this ever abundance world in which we live, right? There's high calorie, low nutrient foods all over, heavily marketed and even targeting children, and they're very addictive. The food scientists do these studies to find these products and make them to the most addictive things possible. They call it the bliss point, right? The point that, everyone just wants more and more of it and can't turn it away. Obviously the genetic things, there are genetic causes of obesity that actually have treatment, some of them, but I'm not going to go into those specific ones today. Then healthcare access, right? Lack of healthcare, inadequate nutrition, decrease in physical activity. The kids are not having, physical activity, PE and sports as much as they used to. And we're just overall more sedentary as a society. We focus on convenience foods and convenience delivery of foods. And then life events, stressful life events, it's real trauma or micro traumas can really contribute to how someone responds. And some people, have the tendency to overeat for coping, right? Or what we call as emotional eating. I mentioned the marketing, advertising these foods can lead to overconsumption. Even just driving around, you see signs everywhere. It makes you want to pull in a drive-through. Mental health issues, obviously, I mentioned this already, but depression can lead to overeating as well. And insufficient sleep, it can cause increased hunger, increased cravings for unhealthy foods. It also elevates our cortisol hormones, and that can affect it as from a metabolic standpoint too. And then there's this stigma of having overweight or obesity individuals that can lead to these unhealthy behaviors such as emotional eating. So this Downey obesity report gives all these 104 different causes or theories of why obesity exists. And I just thought it was interesting to include all these millions of reasons. But in the article that I shared with you, I really like it because it really defines the 4 current models of obesity that are kind of out there right now. So one is the traditional energy balance model. So that's like, calories in is calories out, right? And just to review, a calorie is, something that is measured, right, to raise the heat of a substance by 1 degree Celsius, right? So it's defined by this bomb calorimeter, and our bodies are not bomb calorimeters, right? So we are much more complicated in that, but there is still some usefulness to this because when people cut calories, they lose weight, right? It's just, the calories that you're consuming matter, and that's what kind of goes into the next theory of obesity, which would be the carbohydrate insulin model. So in the carbohydrate insulin model, it's about the quality and type of the carbohydrate in the diet that influences obesity and affects the insulin levels, which insulin is the fat storage hormone. It not only brings sugar into a cell, but it also is a fat storage hormone. So it causes the increase of fat storage, but also decreases the breakdown of fat. So having high insulin levels in this model are what is, the theory that is causing obesity as well. So basically, having an intake of easily digestible carbohydrates, so like refined sugars and refined processed foods, leads to these spikes in insulin, which is promoting the fat storage and weight gain. So the carbohydrate insulin model focuses on how different types of these foods can impact these hormonal responses, and realizing it's not just, calorie content, but the type of the calorie that is more important. And then this energy reduction oxidation model, the redox model. So this model is really focusing on the mitochondrial level. So a reactive oxygen species is produced, during the electron transport chain that can have an extra electron for breakdown from the oxygen consumption. So it's like instead of turning water, it has this extra electron, and that's the reactive oxygen species, and that is basically an inflammatory marker and sets off these cascades that also can affect insulin secretion and metabolic pathways. So this is like really looking at the cellular level of how everything is causing or affecting obesity. And it's a really interesting model. I do think it's like a more newer approach, but it's definitely also part of the contribution to it. And then the obesogen model. So that is the model that is more focusing on environmental chemicals termed obesogens that disrupt the hormone balance and can predispose individuals to obesity. You often might hear this when we're talking about plastics like BPA that can cause hormonal imbalances and maybe early puberty and adolescence these days. Like the puberty times have definitely begotten earlier and earlier, and some of the theories are because of plastics and other chemicals like glyphosate in the soils that we use to treat our farming products. So the theory is that the obesogens basically interfere with the hormonal signaling pathways, promoting fat accumulation and altering metabolic processes. So really, I think it's like an interplay between all 4 of these things. And how I approach it is what are the things that we can control, right? And to what level can we control them? Yeah, I could go get grass-fed beef and avoid plastics and only use glass containers for my family and I, but some of these things are not affordable or possible for everybody. So the part that you can control is the part that you should focus on, I think. So the other big thing about obesity is, why is it so hard to lose weight? And it's because your body is designed to gain it back. We have this set point theory that your body is, you lose a certain amount of weight, but it definitely wants to just keep bringing you back to that set point, wherever it is, okay? So basically you have this basal metabolic rate, and that is basically the amount of energy that your body requires to maintain its basic functions, sleeping, eating, resting, at rest, okay? And then when you lose weight, your basal metabolic rate decreases because there's less body mass to support and move around, right? So you have that lower rate, but then what happens is that your body, the hormonal things happen to get back to that set point. It increases the ghrelin, so it increases that hunger hormone, and that leptin gets decreased, the satiety hormone. And then I don't know if you watched Biggest Loser or have heard about the Biggest Loser studies, but when these patients, they lost significant amount of weight, we're talking like, well, when the study was done, it's significant. They saw 20 to 30 pounds. The basal metabolic rate drops, but then they looked at these individuals, whether they maintained, gained, or didn't regain their weight, or even lost more, they all had a lower metabolic rate. So even those that regained the weight, their basal metabolic rate never recovered. So just think about all the yo-yo dieting that people do throughout their life, and they're just kind of, the basal metabolic rate really doesn't recover very well. And then the hormones, increase the hunger of ghrelin so that you want to eat more to get back to your set point weight. So, and then there's the decrease of non-exercise activity thermogenesis, we call NEAT. So the daily activities that we would be doing, like walking, standing, fidgeting. When weight loss occurs, NEAT tends to decrease as well. So you're not only having a basal metabolic rate reduction, but the NEAT activity reduces, energy expenditure throughout the day as well. So it's really not a friendly thing, but your body wants to gain it back. It's like that famine, the feast or famine thing, that when, basically in the historical perspective of your body is after you've lost a lot of weight, it thinks there's a problem and it wants to gain it back, right? So unfortunately, in the abundant society in which we live, that's not a favorable thing. So the biggest thing after learning or saying all these things, I think the underlying thing here is that it's not the patient's fault, right? Obesity bias is a form of discrimination based on person's weight. People with obesity are constantly shamed and blamed for their disease. I don't know if you saw Oprah's special, but she did a whole thing on shame and blame. And this is because many people, including healthcare professionals and policymakers and others, just don't understand that obesity is a chronic disease. I can't tell you how many people have come to me saying that another provider had said, you just need to eat less, exercise more, right? That it's all willpower. Well, guess what? It's not a lack of willpower or laziness. There's actually, biochemical hormones in the brain. Biochemical neurotransmitters in the brain and hormones that are all dysregulated, that aren't favorable to keeping a lower weight. So the root causes, like we discussed, are multifaceted, from genetics to psychosocial to sociocultural and economic environmental factors. It's essential that the society shifts away from placing blame on those with obesity and instead strive to find more holistic solutions to address this pressing worldwide issue affecting over 630 million people. So we're going to move on that from obesity as a chronic disease and now talk about assessment and evaluation. So we start with the 5 A's of obesity management and then history, exam, and treatment. So the 5 A's of obesity management are ask. So you don't want to assume that they're wanting to talk about it. You need to ask permission. Hey, is it okay if we discuss your weight, or associate it with a certain other medical problem that they have? Okay, you're having that knee pain. Is it okay if we discuss your weight? And then make sure, see if they're actually ready to change. Then you want to assess. So basically, you want to get a complete history and physical. You want to gather their health data and the drivers of their complications of excess weight. You want to advise. So typically, we just talk about all the health benefits of just a modest weight loss, 5 to 10%, and then talk about long-term, strategy and treatment options. Agree. So you want to agree on realistic expectations, targets, and behavior change. In Florida, we have to provide a weight loss bill of rights. That's probably not relevant to you, I hope. And then you want to arrange and assist. You want to identify and address barriers, determine if you're going to treat or refer, and schedule regular follow-ups and provide resources. So first, you want to gather the patient's history. So basically the age of onset of weight changes, the highest weight they were, the lowest weight they were, the rate of the weight gain, and certain life events. You want to look about what they've tried previously for weight loss, what worked, what didn't work, what motivates them to lose weight. You want to know what their past and existing medical issues are. You want to know if they had any operative history like weight loss surgery, or maybe in your case, an orthopedic surgery that led to them to gain weight. You want to know what their current medications are. You want to look for these comorbidities, so depression, diabetes, medullary thyroid cancer, multiple endocrine neoplasia type 2, seizure disorder, gallstones, kidney stones, glaucoma, pancreatitis. Those you'll see in a second why I say all of that. But also look for other comorbidities that may warrant treatment with weight medicine. So basically migraines and depression, we can use medicine that will help both obesity and those things. And then we want to look at family history. So was there a history of obesity? Is there a history of metabolic dysfunction or psychological health issues, cardiovascular issues like premature death, and maybe cancers like breast, colon, and pancreas? And then you want to screen for existing medical conditions. I'm going to mention that in the next slide. And then women's health history, very important. So what's their menstrual history? Are they wanting to get pregnant? Do they have complications of their pregnancy? Are they using contraceptives at this time? Some medications are contraindicated if you're not. Then obviously a tobacco, alcohol, drug use history. And you want to know their nutrition history. What are their current eating patterns? What are their triggers for eating? Is it hunger? Is it anxiety, boredom, reward? If you're sad or you're happy, I always try to see why people are eating or why they have triggers for it. Why they like to go out to eat, or why they're eating out. Maybe it's a financial problem. And then sometimes we do a 24-hour dietary recall too. And then physical activity, what are they currently doing? What are their favorite activities? What are their barriers to physical activity? A lot of people like to say time for that one. Maybe in your cases, there's injuries that are involved. And then the psychosocial part of it. So are they ready to make a change? Are they motivated to make a change? What motivates them, right? What is their occupation? How many hours are they working? Who's on board? What's their family and household like? Who's responsible for cooking? Who's responsible for shopping? Those are all really important things to know. Then their sleep history is very important. Sleep is very much related to obesity. So bedtime and awake time. If they're working the night shift, off really high risk for having weight problems. If they're happy with their sleep, or if they're not sleeping well, if they're waking up tired with headaches, then you need to do sleep apnea investigation. And then life stressors. So, death of a loved one, divorce is a big one, loss of a job, financial trouble, married, moving, chronic illness, injury, all these things, including, emotional trauma, are related to people's weight. Then it really helps to get a weight graph. You want to know the timing and what the circumstances are of what contributed. This is just an example of a doctor's perhaps journey of weight problems, and so high school, college, people tend to gain weight, and then going through medical school, then maybe they get to this later years and they do better. Intern year, you end up gaining weight again, then you get married and you're pregnant. And so like everybody has their own things. It might look different for somebody else. Maybe there's some trauma, divorce, injury, COVID is a big one. All these things are needed to be on a weight graph. And then the medical evaluation. So we do a physical exam. You want to have the right equipment. You don't want to have to go running around finding the right blood pressure cuff. Preferably, you want to weigh the patient in a private room. You want to use waist circumference, neck circumference, perhaps, especially if you're evaluating for sleep apnea, maybe a waist to hip ratio, the BMI, we'll talk about that, body composition, a focused physical exam. So looking for, the skin issues that I mentioned, like acanthosis nigricans, that's the darkening of the skin under the armpits, on the back of the neck, and then skin tags, I mentioned things like that too. Maybe looking at the neck girth and the palate as well. Then labs. So I do mention some of the bariatric procedures here. So if they did have a previous bariatric procedure, it does, dictate we order a little bit more labs. But just standard complete blood count, complete metabolic panel, a lipid panel. I really look at that triglyceride to HDL ratio. That is more indicative of a cardiovascular problem. I want that to be under 2.5. I'll look at the hemoglobin A1C. That's the measure of the sugar over 3 months. Looking for insulin resistance here, which you can also pick up with a 2-hour glucose tolerance test. Also want to rule out thyroid problems. That's the TSH, perhaps uric acid, a CRP, a lipoprotein A, and ApoB. Those are all associated with cardiovascular risk problems and obesity as well. Add on vitamins, the deficiencies if you're concerned. I like to do a lot of, B12 sometimes. And the other things, so screen other disorders, I'll do that in the next slide, and then consider a sleep study. So if you got that large neck circumference, they're waking up with headaches, they're not feeling well rested after sleep, they're stopping breathing while they're sleeping, or they're snoring heavily. Those are all things that might consider a sleep study, because it's really hard to treat obesity if there's an underlying sleep disorder. Then EKG, consider that, and resting metabolic rate. So we just got a new machine in our office that tests the resting metabolic rate, which is kind of exciting, because you can see what the baseline resting metabolic rate is and then track it over time as they progress on to lose and maintain weight. So screening for other comorbidities. I don't know if you athletic trainers use these, but we use that's something called the GAD-7 to assess for anxiety, a PHQ-9 to just assess for depression, a BED-7 to look for binge eating disorder. And there's another disorder called night eating syndrome, where people eat like the mass of their calories after like 9 o'clock at night. I have a screener for that too, but it doesn't have any fancy name. And then obviously ruling out any other eating disorders as well. So using BMI, most of you probably know the normal is 18.5 to 24.9, overweight's 25, and then to 29.9, and obesity is greater than 30. And then we have these different classes of obesity, class 1, class 2, class 3, you can see the breakdown there. And then there's ethnic variation. So actually the Asian and Indian population are found to have more comorbidities associated with obesity at lower BMIs. So we have a different cutoff range for those ethnic populations. And then if you're using percent body fat, you can see the ranges here that we consider normal and those with obesity, and same with the waist circumference. So I also handed out a slide on body composition, and I had all the details of them in there, but we'll go with what I know offhand. So there's different ways to measure body composition. The anthropometric ways are measuring the waist circumference, the waist to hip ratio, and skin fold measurements. Those are the standard ones that we've used for a long time. And then there's hydrodensometry, is basically the water displacement, and they can do calculations that can see what the percent body fat is from that. And then the air displacement play, I can't say the word, but the bod pod, I used that, gosh, I don't remember, many years ago, and it determines, it's a good measurement also of percent body fat. It's pretty accurate. And then the most popular right now, and the one we have in our office, is a bioelectrical impedance analysis. So this is basically measuring the resistance and electrical conductive properties of the tissues of the body, and it can break down the visceral fat, the subcutaneous fat, and the lean mass and everything, and it's pretty accurate as well. Then there's the DEXA scan, which is the current gold standard using dual energy x-rays, and that calculates the bone mass, lean mass, fat mass. And then MRI CT is definitely good, but nobody really uses it because it's not cost effective. I should say about the visceral fat, that is, the fat around the organs and the dangerous fat that causes these comorbidities. So that's why the waist circumference is really important. And it's nice that these other measures can calculate it, though it's still a calculation. But the waist circumference does correlate with the visceral fat level. Okay, so then we have a staging system too. So this is to determine like what are the medical, mental, and possible functional limitations with a patient with obesity has. So stage 0 is no risk factors. Stage 1 is preclinical, so maybe they're getting toward hypertension, maybe diabetes, and minor aches and pains. But stage 2, you're actually having an established obesity-related disease, high blood pressure, diabetes, PCOS, limitations of their ADL. So those are activities of daily living. And then stage 3 would be end organ damage, so heart attack, congestive heart failure, diabetes, limitations of the ADLs again, but it's more significant. And then stage 4, severe disability and end stage and limitations. So they might have had to have a knee replacement, or they had the heart attack, or they have cancer or something like that, that we know is obesity related. And then pharmacology for comorbid conditions. So I was trying to mention this is like, if you have migraines or your patient has migraines and they have obesity, it might be friendly to choose something like topiramate to treat versus using some of the other drugs. I should mention blood pressure because nobody treats first line with beta blockers anymore, but we use these other more weight-friendly medicines. But it's interesting because if you take a person off a beta blocker, it is probably the one type of medicine will that actually you lose weight. Whereas if they gain weight using an SSRI, an antidepressant medicine, they may not lose the weight, but they're certainly not going to gain any more. And the SSRIs are really like patient dependent on whether they're going to gain weight or not. But the point here is to look at all the medicines they're currently taking and try to get rid of those weight promoting medications while working with other providers to make sure that they find that is safe. And then maybe choose something that's more weight friendly. I think some of these, I don't know what the current like doping rules are and everything like that, but a lot of them are probably contraindicated by the NCAA. Okay, so putting it all together, you ask, assess, advise, agree, arrange, assist. You want to get a good history. You want to look at the, patient exam and the data review, and then identify the class of obesity and the stage of obesity. And then you want to initiate treatment and focus on the goals. So biggest thing is preventing further weight gain. And if you can induce weight loss, great. But everybody tends to gain weight, like 2 to 5 pounds a year. So having this, maintaining weight is not a terrible thing too. But we do want to focus trying to get 5 to 10% of weight loss because that can really improve health and reduce risk and really improve the quality of life and prevent complications, obviously. So the comprehensive treatment for patients with obesity, we usually have a couple pillars here, and behavior change, making those lifestyle changes, little habits one at a time, nutrition, focusing on healthy eating habits to maintain a balanced diet, obviously physical activity, and medication if necessary. So medication really helps in that role where you're having that increased hunger as you lose weight. But comprehensive medical treatment is important. All right, so medication and surgery indications based on BMI. So greater than 27, you must have a medical condition. If BMI is greater than 30, you can use the anti-obesity drugs as well. And then BMI greater than 35, they're a candidate for surgery if they have comorbidities as well. And then if over the 40, they can be candidate for surgery as well. But when someone is losing weight, if they're female, if they're of reproductive age, they can increase fertility. So if they're using an anti-obesity medicine, they probably need to have a contraceptive as well. It's not recommended to get pregnant until 1 year after the bariatric and metabolic surgery. And for GLP-1 receptor agonists, you got to stop those 2 months prior to conceiving. So the current anti-obesity medications, I had updated the slide and then it accidentally deleted. So I just threw tirzepatide at the bottom. But so I looked at the NCAA rules and regulations to see if any of these are allowed. So first of all, the stimulants, the phentermine, phendiazmetrazine, and diethylpropion are obviously not allowed in NCAA. They are whatever, you're not allowed to use them. And they are sympathomimetic means. They decrease appetite and food intake, releasing catecholamines in the hypothalamus. Anyone who has a history of cardiovascular disease, glaucoma, or hyperthyroidism or drug use cannot use these as a contraindication, and they are not legal, obviously, in NCAA. And then same with phentermine topiramate. So because it also has the phentermines, all the same things apply, except the topiramate part is an anti-epileptic. It also reduces appetite and food consumption. It's good for that hungry brain or people having cravings. It's also off-label for binge eating disorder. But topiramate is a teratogen, so you have to have like a baseline or good counseling or a baseline and monthly pregnancy test for that one. Orlistat, I don't really know anybody that uses it, but it's a pancreatic lipase inhibitor. It decreases absorption of fat. So basically you're pooping out fat. People don't like it because it causes diarrhea. So nobody really prescribes it. But they have the over-the-counter version, blanking on the name, but there's an over-the-counter version of this medication. Ally, I think, A-L-L-I. Okay, bupropion naltrexone. This is working on that reward craving pathway. So bupropion is also used for smoking cessation, and naltrexone is also used for alcohol. So putting those two together, and bupropion is also an antidepressant, really hits that emotional hunger. Those who eat, responds to positive or negative emotions. So those are good candidates for that. And then it's contraindicated in uncontrolled blood pressure, seizure disorder, because bupropion can lower the seizure threshold. Any disordered eating, especially bulimia, because of, once again, the seizure threshold and electrolyte abnormalities, and anyone with opioid use, because we can't reverse, opioid toxicity with naltrexone if that's the case. So that's working on that reward pathway to regulate appetite and reduce cravings. These ones show like modest weight loss, and everybody was kind of overlooking them in the past because it's not like as impressive as these newer drugs that we've been talking about in the last 2 years. So liraglutide has been around forever. It's a GLP-1 receptor agonist. It increases satiety, decreases food intake and appetite via that GLP-1 receptor in the brain. So it's acting on the gut and the brain to decrease slow gastric emptying and increase satiety. So it works for those who really have trouble not eating, like grazing all day long, or can't not eat between meals. Contraindications: multiple endocrine neoplasia type 2 and medullary thyroid cancer, and maybe a personal history of pancreatitis. I don't know if you've heard of the news, but sometimes that can be related. But these thyroid things were all done in rats, so we've not seen that in humans yet. Semaglutide, the ever popular one right now with a couple of different branded names. It's a GL1 receptor agonist, used the same way. It's just worked better. I had the weight loss percentages down, but I think it's like around 15% of weight loss, where all the other ones are more like 5 or 8. It's not that much more than lifestyle alone. And then tirzepatide is a GLP-1 GIP receptor agonist, and that once again works in the brain and in the gut to delay gastric emptying and increase satiety. And that had up to like 23% weight loss. This is why these are getting much more buzzy in the news. And it has now a branded for obesity and for diabetes, and same with the semaglutide. And then there's this non-absorbable cellulose hydrogel. I think it actually was taken off the market. It had I can't remember the brand name, but one of my patients recently asked for it, and we couldn't find it. So I don't think they're really doing it, but it basically was a particle that you took before meals, and it absorbed water in the stomach to make you feel full. It's like drinking a whole bunch of water before eating, which is not a bad thing. So the goal really is to achieve that 5 to 10% reduction in weight in about 6 months with lifestyle interventions and with or without medication. So with lifestyle intervention, it's usually not cosmetic, but it usually will treat the patient's health and complications of obesity. If they don't lose weight in 3 to 4 months, they're supposed to be considered a non-responder and stop the medicine or switch it or add on medication. And really the important thing is that obesity is a long-term process. It's a chronic disease. It waxes and wanes. It comes and goes. Like someone may be good one year and the next year, maybe they had a trauma or a life change that something isn't working for them anymore. So we're supposed to use the medications. They work as long as they are used. However, like if usually all the studies on these FDA approved medicines show that if you stop them, then there's weight regain. There is an FDA warning on compounded semaglutide. I'm not sure if you read all of that, but Obesity Medicine Association has a position statement about it. Just there are potential risks because you want to make sure that you get a safe, effective drug. The ones with salts and other additives are not considered safe and could cause serious harm. Remember, this drug does cross the blood-brain barrier. So obesity is chronic disease. Long-term treatment is long-term medication treatment is recommended. And basically, you want to identify any medications that are that are making the problem worse, and transition to weight neutral or weight favorable medications. You want to consider anti-obesity medications and prescribe if appropriate, and look for cues, contraindications, and comorbidities, and reassess the medicine and consider combination. I'm going to go a little faster because I think I'm running out of time. But as far as the nutrition, it's really beyond the calories. You want to understand the importance that it's to maintain a healthy lifestyle. I always talk about fueling your body with the right foods, right? Focus on the quality of calories, not just the calories themselves. Not all of them are created equal. You want to choose, whole foods, not processed things. And find a diet that works for the patient. I don't like the word diet, but if they can stick to some sort of lifestyle nutritional plan, that's the one they should be doing. If you can't do keto for your life, it's probably not for you, right? So personal preference, ethnic or religious, allergies or food intolerances, comorbidities, all these things should be considered based upon their nutritional needs. Consider a referral to a dietitian if you need help. So making healthy eating choices. So limiting highly processed foods. We call these ultra processed foods. There's actually a NOVA classification scale that describes 4 different tiers of processed food. You really want to avoid the 3 sometimes, but 1 and 2 are not bad, meaning like processed meat might be stored with a little salt for preservation, and that's a lot better than the list of ingredients that you can't even pronounce on the back of something down the middle aisle at the grocery store. You want to limit energy-dense beverages, so basically sugar-sweetened beverages, try to avoid those, and treat treats as treats, right? Don't have them every day, make it a special occasion. You want to encourage consumptions of healthy proteins and fats, nuts, fish, seeds, vegetables, leafy greens, fruits, berries, really like a variety of fruits and veggies, like 20 to 40 per week is supposed to be very good for the gut. You want to do that for balanced meals, and then complex carbs over simple carbs. So you want to do more of the whole grain, avoid the white bread and white rice, but do brown rice and whole grain bread. And then read labels rather than marketing claims. Everything can say organic, but it still might be a bunch of junk in there. If you can't pronounce the ingredients or the list is long, it's probably not a good product. That's usually a good thing. And then really watch the added sugar. That's usually, in my opinion, the biggest poison. And then beyond nutrition, the behaviors are very important. So typically the motivational triad of our little toddler brain is to seek pleasure, avoid pain, and conserve energy. So you want to use the executive brain to make a plan, to be future focused. And that was the one that has, your goals on board. So really focusing on overriding that natural motivation, you have to write things down, make a plan. And that's why I usually try to have someone create an eating plan ahead of time. A lot of patients have trouble with it, so I do what they can, but you want to make sure that the patient can stick to it and make sure that it's doable. Food logs are great. You don't have to do calorie counting if you don't want to, but really just being mindful of what you're putting in your body is the important thing. And for emotional eating, you want to definitely address and solve the emotion behind the eating habit and consider medications if needed for that. But make sure they stop and pause and say, hey, why am I eating this? Am I truly physically hungry? So exercise, I probably am preaching to the choir here, but it's important for health, for chronic disease, improve mental health, increase energy levels, reduce stress, start slowly and gradually, increase the intensity and duration, maybe the weight, and do something that you find enjoyable and fun and make it a new habit. We talk about non-exercise activity thermogenesis and exercise associated thermogenesis. NEAT is like standing, walking a little more, just anything you're walking around the house, just being more active. And I think that's really what we're missing in society. So any intentional purpose to increase need activity is important. And then exercise is also important too. They're very hesitant to start. You want to assess their readiness to exercise, maybe start with low or no impact activities, balance training, strength training, and really just create the habit. I don't know if you've read Atomic Habits by James Clear, but it's an excellent book that really details how to make good habits and keep building upon them. Current exercise guidelines, we usually say 150 minutes of moderate activity a week, and then also strength training on all major muscle groups 2 or more days a week. This just kind of shows a difference of if you did it, how many minutes you would need to do per activity, and just encourage movement to move more, sit less, etc. throughout the day. Types of exercise, so we're really focusing on that strength training when we're prescribing GLP-1s and to reduce that basal metabolic rate loss and to avoid sarcopenic obesity, which is really low muscle mass. So I like this one, cardiorespiratory exercise, maybe just walking like 75 to 300 minutes a week, strength or resistance training twice a week, and flexibility 2 to 3 times a week. So you can see how if to prevent regain, you need a whole lot more activity than to prevent just regular weight gain. So behavior strategies, once again, I would go back to Atomic Habits, but establish a routine, build consistency, set small achievable goals and build on success, focus on sustainability. Self-monitoring is really important, especially even with fitness, like setting goals, see how you've improved. And then you give yourself rewards, but non-food rewards, and small and frequent. It helps keep up motivation and keep temptations out of your environment. Don't bring things into the home. Those are simple behavioral things you can work on. And really just empower your patients. Let them know that they got this, they can do it. We're not after perfection. We're not after a normal BMI. We're after improvement. And, we want to know and teach that obesity is a chronic disease. It's set by our genes in the modern world because our genetics were not meant to live in this world, and that, they can do this. So yeah, and support and empower your patients to create these habits. So obesity is a serious medical condition and can have negative impact on our physical, mental, and metabolic health. It's caused by a complex interplay of our body's genes, biology, and brain in the modern world. These are my references. And let me know if you have any more questions. You can find me at all these locations. And I'm sorry it was so long, but that's all I got.
Okay.
All right, great. Well, thank you so much.
Or are we out of time?
Yeah, I'm gonna. Well, we can give them a couple minutes here to pose their questions in the question box, and then as they pose questions, I'll relay them to you, just letting you know kind of who asked the questions that we did. It looks like, in case you're curious, we had at some point in time, I haven't looked at this before. It says 88 here and 154 gone. So I'm not sure if there was like 230 people coming and going. I'm not positive.
Okay.
Certainly. And a very high attentive rate, looks like.
Great, good.
Yeah.
I know I spoke fast, but there was so much to get through.
It was a lot of material. It's almost like one to go back and, for the attendees to go and rewatch and, kind of get prepared for whatever the quiz questions are.
Yeah.
But also, relevant for their patients too. I know I've seen quite a few folks with, some of those like stage 1, stage 2 symptom issues.
I really think the biggest thing is, probably prevention at this point, so they can really learn and understand what is the cause, right? And then how can they prevent it going forward and not have these same stories end up of athletes or anybody getting later in life. Yeah.
Exactly. Yeah, I love how you mentioned that, like kind of, for the kids who are in college and they're retiring now, and they'd had, a certain expectation of activity and lifestyle, and that was kind of balancing out their nutrition decisions.
I swear there were going to be questions on the GLP-1s.
Yeah, actually, and you know, I would say that with those are you finding that they will get approved for straight obesity now, or does it have to have diabetes, type 2 diabetes in it?
So I was trying not to say any brands, but the approved brands are Wegovy and Zepbound. So that is semaglutide and tirzepatide, respectively. Those are approved for obesity, and they're actually approved for cardiovascular disease prevention too. So we're seeing more coverage, even in Medicare, if you can prove, you know, the cardiovascular outcomes that can be prevented as well. So if they have obesity and have that, then they're definitely getting approved. And then for diabetes, it's Ozempic and Mounjaro and all the other traditional ones that have already been around for a while. But those are definitely approved for diabetes, and those are easier to get coverage. But the problem right now is supply, which is why I mentioned the compounded thing, because the supply and demand is over the top right now.
And then on a separate, on a part, in terms of you were talking about movement. Have you guys ever done any kind of step challenges where, I just bring this up because at our office, we are, as a team, we are, you know, just trying to hit like a basic minimum number of steps. And we have had a lot of difficulty finding an app to be able to have all of our steps communicate with each other to motivate and inspire.
There are some things. So I have a remote patient monitoring that I do, and we give people their home bioelectrical impedance scale, and they can sync like Fitbits and things like that in the app, and we can see it. And I tried to switch companies, and the other company does do those kind of challenge things where you can all be integrated in the same platform. But everybody hated it otherwise, so I got rid of it. But I think that's fantastic. I haven't done any challenges. There's a lot of people who do a lot of group visits for obesity medicine, and I think that would probably be a good place for that. But I like really want to develop my own app because I just cannot find what I want for my patients exactly, because I want the ability to write things down, but not necessarily have to track the calories and the macronutrients. While I think they're all important, it may work for some, but it doesn't always work for everybody. So finding like that middle ground is a little bit harder. But I like the idea of like the team challenge, right? So that's something I could definitely do in our office, would be to get my staff more on board, as to do these like team challenges too, not just with patients, but with staff too. So I think that's great, but there are some macronutrient tracking. I mean, there's an app for everything, but I haven't found one. I'll look into it though, to have a group like challenge. I don't know.
We have a question that came in from Alexandra, and she asked, do you think the media coverage on Ozempic is overall a positive or negative thing for obesity awareness?
For awareness. Okay, so I do think it's a positive thing for awareness, right? People are understanding, I think, more, especially even with like Oprah's coverage, that it's a disease, right? And it's appropriate to medically treat it in the right circumstances, right? So I think that it's good. Unfortunately, Ozempic is for diabetes, but its counterpart, Wegovy, is for obesity. But I don't know. I think that coverage part is good, and it's important to know, you know, what the side effects are, right? I didn't go into that much, but like, you know, there is diarrhea, nausea, constipation, the rare risk of pancreatitis as well. So those things are, you know, I think that's good. And I think, I mean, the negative parts of it is just that now I feel like it could really induce in our society like more yo-yo dieting if the wrong person gets a hold of the medicine. Because you really, like it said, like 27 BMI with comorbidities, right? Or BMI above 30 is indicated. But I know there's plenty of people out there that are using it for lower BMI numbers, and typically, you know, we were seeing that in the Hollywood area and stuff like that. Well, many Hollywood people may be eligible, you know, a lot of them were just taking quick weight loss.
Awesome. Well, great. Well, thank you so much for your time. I will share with you the feedback that we get from the attendees. Like I said, there was quite a few, so I'm sure we'll get lots of good feedback here. And then for all of our attendees, thank you very much for attending. If you have additional topics, additional speakers that you would like for us to have a future journal club, we would certainly be happy to reach out to those folks or find speakers on topics of your request. You always keep us guessing and have very interesting, unique requests, and so this certainly was born from one of those. So please continue to put in those requests. And like I said, thank you, Dr. Reller, again for your time today. I really appreciate it.
Thank you for having me.
All right. Have a good day, everyone.
Bye.